Hello, welcome to, let me go to the front slide. Unit 10, we are covering lifespan. So we talked about this in class. It's a lot of chapters, but a lot of this is also stuff we have talked about all quarter. So almost none of this should be new. I think there's maybe one or two things that are really new in this section. So in childhood, healthcare providers who work with children must have an understanding of normal growth and development, right? We need to know what is appropriate and when we need to refer out for further testing. That's the biggest thing of it. When is a child deviating from what is normal developmental tasks, right? Children are going to grow in physical size. Their skills and abilities are going to enhance over time. Two types of growth, head to tail and near to far, and it's a continuous process. It doesn't stop ever. Common behavioral problems, right? In babies, we got colic. Just cry, right, for longer than 3 hours every day for more than 3 weeks. Feeding disorders, overeating to undereating. Sleep problems. Kids never sleep, ever. Night terrors, problems falling asleep, nighttime awakenings. Temper tantrums, super common between the ages of 1 and 4. 50 to 80% of children will have temper tantrums, right? Breath holding spells. Sounds like just it is. Kids get upset, they hold their breath until they pass out. Can happen from 6 months and last until 5 years. They tend to grow out of these. The diagnosis, right, is less important than the person, especially when we talk about mental health in childhood. Right, there are 7 major characters, but we have to look at each child as an individual. This is that person first. And just like everyone else, right, absence of growth, inability to change, failure to achieve a task, we should seek mental health assistance. There's tons of different providers kids can see. Environmental problems, right? Children who are poor or homeless, who are abused or neglected, they have different problems than a kid who grows up in suburbia, right? Neglect, not meeting a child's basic needs, food, clothing, love, and belonging. And sometimes it's not intentional. Right? We talk about those ACEs. If you have a single parent home and that parent is working 3 jobs trying to survive, they might be neglecting, but it's not out of hate. It's just because they can't. And that leads to parent-child interaction problems. Parents need to set limits and enforce them consistently to provide a stable environment for their children. Right? Children need to test limits in a healthy way. And no child or parent is going to escape without conflict. It just happens. I swear my kids hate me like on a daily basis for some reason or another. I told my kid he's going to get a toy at Target today. I set a limit, right? Primary caregiver dysfunction happens when for whatever reason a parent cannot meet the needs of the child. It could be because the parent has mental health or substance abuse issues. It could be due to physical illness in the parent. If you have a parent with, cancer, they might not be able to be there at all. Emotional problems, anxiety. All the way down to infants. Infants and toddlers have separation anxiety. Once kids start to go to school, they have school avoidance. Most anxiety in children are relieved, though, when they just get emotional support, when they know everything's going to be okay, and they have someone else they can turn to. If the anxiety does not interfere with relations, family, school, friends, it shows that the child is coping, right? In everyone, anxiety is normal. It's called eustress, good stress. Depression, right? It's a symptom, an emotional state, or major depressive disorder, your clinical syndrome. Persistent state of unhappiness that interferes with pleasure or productivity. We want to reduce the problems that's causing the depression and help the child cope effectively. Children are going to be a little different in how they exhibit the symptoms, and they might not directly verbalize hopelessness or sadness. They might not always lead to, and they might not always act sad, which sometimes misleads adults to think that a mood change is temporary. Somatoform disorder. We have talked about this before, right? My kid got in trouble at school, and next thing you know, his stomach hurts. Oh, clicked a button too soon, and you can hear them yelling in the background. Right? You have a test at school and your stomach hurt. Now the kids, the school nurse calling and they have a math test last period. When stress is relieved, child returns to a healthy level of functioning. Children with somatoform disorders need understanding and reassurance. PTSD, just like in adults, right? I'm going to keep saying that with almost every one of these. There's a traumatic event and there's an injury or something that threatens the child. They relieve the traumatic event repeatedly, and it leads to lots of symptoms. Fearfulness, nightmares, loss of appetite, drug use, isolation. Treatment focuses on recognizing and then emotionally supportive care. Behavioral problems, right? Aggression are common in school. There's bullying, there's intimidation. Children might see violence at home, right? Behavioral theory, we learn what we live, we learn what we see. So if children see violence at home, that might be their way to solve a problem. If a child's conduct becomes inappropriate, we might get a disruptive behavioral disorder. Two types are usually ADHD and conduct disorder. Children in electronic media. By 2, more than 90% of American children have an online history, right? Increased unsupervised exposure to media can result in hyperactivity, stress, anxiety, eating disorders, impulse control. Children can't distinguish reality from fantasy. Cyberbullying is occur, and they're going to spend more time with the device than with their families. ADHD, the most commonly diagnosed mental health problem in childhood, more frequent in boys, and it's a syndrome, a cluster of symptoms related to not being able to pay attention or being able to sit still. Excessive talking, disorganization, right? They're daydreaming, they just make mistakes, they forget about deadlines. It's multidisciplinary, and the kids need positive reinforcement, right? Parent and child education, and then medication. We tend to use stimulants as the medication of choice for ADHD. Dextroamphetamine is one, right? Adderall, Ritalin, Concerta, but they have to be closely monitored when taking these medications, right? We have to avoid caffeine in these patients, especially while on a stimulant, because too much caffeine while taking a stimulant is not good. We have to monitor the effects of growth long term, so monthly height and weights maybe every few months depending on how they're doing. We have to monitor for excess energy, right? Because these are stimulants. Is it making the child more energetic? But then, and also cardiac, right? Tachycardia, hypertension can result as side effects of these medications. So, disruptive behavioral conduct disorder, right? Children with conduct disorder defy authority as a whole. Conduct disorder is broken up into 2. I don't like this slide. I like this slide that we did previously in anger, right? So conduct disorders. Pattern of behavior where the basic rights of others or societal norms or rules are violated, right? These are baby psychopaths, right? Baby antisocial personality disorders. They don't care about you. They don't care about your property or your rights, right? These are kids who are going to steal your stuff and not think twice about it. They're going to resort to vandalism, right? They're going to bust open car windows just to take a charging cable because they can, because who cares? Oppositional defiant disorder is authority figures. Negative aggressive behaviors that focus on the authority figures in the child's life. And the authority figure could be anyone, right? It could be the school bus driver. It could be the teacher's aide. It could be the gym coach, right? Oppositional defiant disorder, hostile behavior towards an authority figure. Treatment, family therapy that stresses limit setting and consistency. Eating and elimination, right? Children with problems eating are defined as routinely failing to eat adequately. There can be a lot of different reasons, right? An irritable infant, someone who has, an infant with reflux or eating disorders. Parental mental health problems. There was one case study about a parent with mental health who kept feeding her kids vitamin gummies until she had completely messed up her kids' electrolytes because she just didn't think vitamins were bad. Or it could be abuse and neglect, where kids just aren't allowed to eat and they're starved. We have to rule out the cause, especially in younger infants. Is it something that's going on with the child? Or is it something that's going on with the parent? Pica, we talked about pica last week too, right? Eating a non-food item for longer than a month. It's seen in MR, it's seen in developmental disorders, vitamin deficiencies, and mineral deficiencies. Rumination disorder is that regurgitating of food. So you eat and chew something, you regurgitate it, and then you re-chew the food and eat it up again. This they grow out of it as a child gets older. There may be some malnutrition and rumination disorder. Problems with eating and elimination continued. Enuresis, right? It's urinary incontinence in a child over 5. Secondary enuresis is after the child has already achieved bladder control. So this is a child who has already been potty trained and now they're wetting the bed again, or wetting their pants during the day. Encoparesis, repeated, sometimes voluntary, passing of feces in inappropriate places in a child older than 4. Right? There's no physical reason why this should happen. This was not previously a problem, and now all of a sudden they're pooping in a corner. Intellectual disabilities, right? Score 70 or lower on an IQ test. Right? Fetal alcohol syndrome, we talked about that before, leading known cause of intellectual disability in children. But we also have to look at the whole child. How do they cope with life? Someone can have 120 IQ and not cope with life, and someone can have a 68 and are doing okay. Developmental problems, learning disorders. There's lots and lots and lots of different types of learning disorders, right? Dyslexia is a common one. Letters are flipped around. ADHD. Children with learning disabilities often have low self-esteem and lack social skills of other children. A child has a learning disorder if it interferes with academic children's and activities of daily life. These are some type of how where learning disabilities may interfere: oral, reading, written, math, organization, social skills. But you also have all different types, right? Processing speed. You might have difficulty with memory or executive function. That's that frontal lobe. Communication disorders. You can't communicate normally. It could be neurologic, it could be medical, there could be no other reason. Phonologic, you're not using the sounds that is expected for your age. Expressive language disorder, speaking rapid or slow or using strained rhythms or word, but you cannot expressively communicate, so you can't communicate to someone else. Stuttering, pattern of speech in which sounds are repeated frequently. Your pervasive developmental orders, right? These affect the whole of the child, right? They have difficulty with social interactions, communication skills, and learning. The most common of these that is diagnosed is autism, right? Rett syndrome is they progress normally, and then somewhere between up until 5 months or 4 years of age, somewhere in there, and then they lose their previous skills. And you actually see growth decline, head growth, strange hand movements, loss of social interest, severe speech impairments. Childhood disintegrative disorder, it's a severe regression after 2 years of normal development. Right? So what do we see in autism? They prefer to play alone, does not respond to their own name even after 12 months, does not share common interests with others, flat or inappropriate facial expressions, only interacts to achieve a desired goal, avoids or resists physical contact, they might not want to be held, trouble understanding others' feelings or talking about their own feelings, does not understand personal space or boundaries, is not always comforted by others during distress, and avoids eye contact, right? They're not going to speak like everyone, they're not going to socialize, and they're not going to communicate, right? They might have one specific thing that they become preoccupied with, one specific object. You heard my kid running around earlier. He is preoccupied right now with, maybe it's Lightning McQueen today, and that's all he's going to focus on, right? But it's a spectrum, and kids are going to be at different points of this spectrum. And even teens and adults who have autism spectrum disorder are going to be at different points of it. Schizophrenia, just like in adults, right? Lack of contact with reality. That's the definition of psychosis, right? So you have the psychosis, they retreat into their own world, And just like in adults, we have to recognize and treat it early because it is a long-term disorder. Therapeutic actions with kids. Early identification and treatment. Pediatricians, early childhood intervention programs, school districts all have ways to get children in and to get screened. We have to meet basic physical needs, Maslow's, right? We have to meet mental health problems and special needs, right? The caregiver may be the only person available to provide for those needs. We have to provide support to caregivers in teaching their child how to grow, right? Self-care activities and independence. How can you encourage independence in some of these children? So after this, we went into adolescence, chapter 14. It is not much different than pediatric patients, right? You have early adolescence, which is, middle school. Middle adolescence is high school. But then also 18 to 24 is technically late adolescence and early adulthood. Why? The frontal lobe is still developing. At 22, your brain's not fully developed. There's tons of changes going on in adolescence, right? Rapid growth again. And we have to understand how these adolescents are growing and changing because many adult problems start in adolescence. Maturation, the process of attaining complete development. Right? Puberty, sexual development. Menarche in girls starts about 12, some younger. Males start to hit puberty between 11 until about 14 is when they start. And it generally lasts until about 18, right? Boys grow slower and develop slower, especially in maturity, than girls. Psychosocial, non-physical, right? Intellectual, emotional, social, spiritual. Everything is changing in adolescence. Internal problems, right? What are stress in adolescence? How do their self-esteem, their self-confidence, right? How is that jeopardized? How is it changing as they grow from adolescence to adulthood? External problems, right? Problems outside the teen. Physical violence, sexual abuse, neglect, parents who are abusing alcohol and drugs are still a problem. We are very good at assessing pediatric patients, right? Younger pediatric babies, elementary school for abuse. However, adolescents are still often abused, so we have to assess. You also have gangs, peer groups, and intimacy struggles, right? Problems in their environment threaten their basic needs. Family problems happen, right? Adolescents want to be independent, and they're kind of pushing and pulling between the family saying, hey, this is what you're doing. You live it right in my house, my rules. Versus the adolescent saying, screw you, mom and dad. I want to do what I want to do. I am going to argue, I'm going to look up the statistic because I think it's wrong. 54% of teens send text messages daily. It's probably more than that. 6 hours of media every day for kids. Multitask. They're doing other things while doing homework. I bet y'all are doing it too. Social media, electronics have a strong influence on teenagers and adolescents, right? TikTok challenges. Mental health skills for adolescents. Positive life skills. Prevention of mental health, right? Those ACEs. Those 10 things that we have to prevent or find a way to circumnavigate or reinforce to promote better health in kids, and then the treatment of dysfunction, right? Dysfunction is an impairment in everyday life. We're going to provide health education, right? Teach adolescents how to use a condom. Assist with group therapy, individual therapy, medication management, setting limits. Providing emotional support, having a role model, an adult they can turn to and talk to if something's going on. Behavioral disorders exhibit themselves in teens when there's a disruption to families, social interactions, and performance in school. Was there a teen who was doing fine through, elementary school, got decent grades, 6th grade did okay, and then in 7th and 8th grade, all of a sudden they're failing, right? Just like in the younger pediatric patients, ADHD and conduct disorders. Emotional disorders, right? Anxiety. The ability to adapt and cope is overwhelmed. That's been the definition, right, of crisis, anxiety, mental health all semester. Mood disorders, depression to hyperactivity. Depression, irritable moods, acting out behaviors. So we see it a little bit more, right? In kids and adolescents with depression, we can also see decreased school performance, social anxiety, hopelessness, difficulty thinking and concentrating, not as good at making decisions, physical complaints, loss of energy, headaches, nausea, stomach pain, problems with sleep, more so than normal, right? Adolescents still need a decent amount of sleep in the early adolescence. And maybe they're not sleeping at all, or maybe they're sleeping 12 hours a day. Eating disorders, right? These should not be anything crazy because we just talked about these last week. Severe disturbances in eating behavior, right? Obesity, overweight, anorexia, prolonged refusal to eat to keep body weight. We generally see anorexia start in the teenage years after puberty. There's usually a controlling parent, and the child uses the refusal to eat as a way to control their behavior. It is usually a female. They are usually strict and rigid, trying to please others. Let's see. They're going to push around their food. There's might be excessive exercise with anorexia. And they have this fear of just being fat, right? And they're going to have a low BMI. Bulimia is going to have a normal BMI, and it's a cycle of binge eating followed by purging. You don't normally see the exercising in bulimia, but you see the purging, whether it's making themselves vomit or laxatives, making themselves poop a lot, and they're going to be shameful. This is going to be their secret. And they might go and have, the whole giant family-sized box of Oreos and then puke it up again. So you see the dental problems, right? And in both of them, in anorexia, you have refeeding syndrome. And in bulimia, just from all the vomiting and diarrhea, electrolyte imbalance, specifically hypokalemia, makes these some of the most deadly psychiatric disorders. An individual with an eating disorder dies every 62 minutes. Right? 3 goals for the treatment of eating disorders. We need to manage the medical dangers. Are they extremely dehydrated? Then we need to rehydrate them. Right? We have to watch those electrolytes. Next is to restore normal nutritional and eating patterns. Right? We are not talking about like going out and binge eating. We're talking about going and having a normal meal, and they're making those decisions independently, not because we said, you need to sit down and eat this. Finally, we're going to look at the psychiatric treatment and needs of the client and the family. Let's do family therapy. Let's get the client involved with therapy. Let's get to the underlying root of the issues. But we have to first manage medical and nutrition. Chemical dependency, right? Using drugs. Kids also often use them to cope. Substance use, accidents, interpersonal violence, depression, worsening relations for others. Accidental causes of death are the top 3 leading causes of deaths in teenagers. There's various stages of chemical dependency. Personality disorders, just kind of like personality disorders in adults, right? Inappropriate or maladaptive behaviors. They can be given the diagnosis of a personality disorder. Usually we wait till they're 18. You're not going to give this to like a 13-year-old. You're just not. Treatment for personality disorders, just like in adults, psychotherapy and SSRIs, right? SSRIs are usually our first line for just about anything. Even if we have a teen with an eating disorder, we're going to do an SSRI. Sexual disorders, distress and impaired functioning. Gender identity disorders, right? Gender dysphoria. You see that a lot in pediatric patients. Biologically male identifies as a female, so they dress like a female. Many problems faced by adolescents can be solved with the use of good communication skills. But let's face it, no teenager wants to talk to their parents about sex. So that's where we're there as healthcare providers. When they come into the clinics, wherever you are, if you're a school nurse, we need to be able to talk to the patients. Replace ignorant with accurate knowledge. I have met some teenage psychiatric patients before who know absolutely nothing about sex, or actually they think they know everything, but it's all wrong. We have to provide this knowledge and teach them so they can have a healthy sexual maturity. Psychosis. We talked about this with schizophrenia, right? Detachment from reality. Here it is, loss of contact with reality. Just like in adults, right? Psychotherapy, antipsychotics, antidepressants, lithium. Suicide. Adolescent girls are going to attempt more than males. However, males are going to be more successful because they use more lethal methods. Teenagers who attempt suicide are in 3 groups. Depression, they're trying to influence others, or they have serious mental health problems. Teens with eating disorders are highly likely to kill themselves, and eating disorders in general increase your risk of suicide. You have suicide clusters, which we often see in schools. Well, 13 Reasons Why. Following the release of 13 Reasons Why initially, there was an increase in suicides in teenagers because it's like, hey, look, this is suicide. This is how you do it. It's cool. Goals of treatment. We want to protect teens from harm, keep them safe. Number one thing will always be safety. Building a trusting therapeutic relationship kind of ties and is the next step. Assist them in developing self-awareness and coping skills. What can we do to help get them through this? Warning signs, right? A straight A student who's now failing. They were in clubs and groups and now they have no interest. Emotional highs and lows. They won't always seem depressed. Sometimes they'll seem okay and then they drop to rock bottom. And then they'll seem okay and go back to rock bottom. Pushing limits, secretive, withdrawn from family, changes in personality, nightmares, isolation, discussing suicide with peers, right? Googling how to kill yourself. So what do? Surveillance, we have to keep an eye on them. We have to see what they're doing. Kids don't get any privacy, right? Limit setting. And limit setting is encouraging responsibility. We're not trying to be mean, but we need the kids to be responsible for their actions, and that involves setting limits. This is what you can do, so that is what they should do. Building self-esteem and self-confidence, role modeling good skills, and then developing their skills, problem solving, social skills, all sorts of skills. How do we build self-esteem? We model it. We use eye contact. We address everyone by their name. We listen. We're respectful. We have them assume responsibilities. Praise the effort at changing, not necessarily the behavior that changed, but hey, you've worked really hard at doing this. I've seen you, showing up early to practice every day and doing this, this, and this. That is all that hard work is what led to the positive outcome. Not just saying like, hey, good job, you got an A, right? We have to teach problem solving skills, limits again, and responsibilities. Caregivers are going to help teens, right? Whether it's the parents or a school nurse, right? Develop effective living skills. How do you live as you're getting older? You go out to an apartment on your own at 18. How do you do your laundry? We have to intervene in childhood and adolescence to prevent future problems. If the anxiety is left to continue, right? If the depression is left to continue, it only worsens. This is kind of our last ditch attempt to get on board and get the kid moving in the right direction.